Hi, everyone. I'm Melanie Escher with the Arizona Telemedicine Program, Southwest Telehealth Resource Center, and welcome to our webinar series. This is a new series that we're doing. It is on tele-applications and services. Instead of an all-day session or half-day session, we're going to be doing deep dives an hour at a time in various tele-applications and services. We respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The Southwest Telehealth Resource Center represents Colorado, Arizona, New Mexico, Nevada, and the Four Corners region, with a combined total of 72 recognized tribes. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. So some webinar tips and notes. So when you join today, your phone or your computer microphone were muted. We do have time reserved at the end for questions and answers. So please use that chat function to ask your questions. And as Dr. Gibson is going along and doing her presentation, if a question comes to mind, please go ahead and put it in that chat. We also have a post-webinar evaluation that will populate in a screen behind this, behind your Zoom link, but I will also be putting it in a thank you email to everybody that has logged on today. If for some reason you need to leave early, that's okay. I will still send you that email, and if you've got any questions, you can ask there as well. So it is being recorded, and it will be on our website later. So this was sent out to everybody that registered, plus it was on the registration list. I'm not going to read through it all, but these are the outcome objectives that Dr. Gibson had identified. And the accreditation statement with the university, and it is, we do have CME credits. Everyone is welcome to a certificate. Again, I'll have some information in that thank you email to you on how you can request those and get those to you. There's an attendance tracking process here when we do these 1-hour webinars, and it's through the College of Medicine, Tucson, the Accreditation Council for Continuing Medical Education. They have a portal called Cloud CME, and you'll be able to plug in a code for your attendance, especially for our physicians. You can get a printout of all of the different sessions that you've attended for the year with us. Have our standard disclaimer. I think you can all read that. And we'll continue on here. So please check our website for upcoming webinars and events. Again, this information will be in that thank you email, so you can link on it later. And this is the evaluation link. I'll put it in the chat as well. You don't need to worry about copying it right now. And without any further ado, I have the great pleasure to introduce Dr. Gibson. She's coming to us live from her offices up in Flagstaff, and she's got a lot of information to share with us today. She's been working with us for many years. She is an accomplished psychiatrist and has been doing telepsychiatry for 30 plus years now. Is that right?
Yeah.
So
29, I think, is the number.
So without any further ado, I'm going to go ahead and stop sharing my screen so she can get her screen up, and we will get started here.
All right.
And Dr. Gibson, I will go ahead and pass the mic over to you.
All right. How's my view?
Everything looks great. Thank you.
Okay, great. All right. Well, welcome. Yes, as Melanie said, I've been doing this a long time. I'm going to speak to you today mostly from the lens of a psychiatrist, but about telemental health in general. A very long time ago in a galaxy far, far away, northern Arizona, we were looking at this huge geographical barrier and remote access to care for mental health and behavioral health services throughout northern Arizona. The Regional Behavioral Health Authority for Northern Arizona, then NARBA, shared a grant with the University of Arizona to start this program called telemedicine that nobody had heard of before, because we had a problem. We were supposed to be overseeing all this mental health care for this vast area of northern Arizona, almost two-thirds of the state, but only 11% of the actual population of Arizona. And as you can see from this little map, Arizona has got these little tiny towns with vast areas of space in between them. And so people were driving all over. In addition, we have a health professional shortage area in mental health. This is a national HRSA definition. This is a current map, but basically, if it's in blue, it's a shortage area. And so essentially, the need for mental health services vastly exceeds the supply. So, with a great deal of courage and necessity, we started telepsychiatry, telemedicine in 1996. I was in Flagstaff and I was providing, if you can see this little purple county over here, that's Apache County, the non-reservation part of Apache County is what we were in charge of. So St. John's, there were two clinics that were part of Little Colorado Behavioral Health Centers that served this county, St. John's, which is a 3-hour drive, and Springerville, which is 3 hours and 20-minute drive. And since 96, almost all of the services to this county have been provided via telemedicine. So well over 30,000 sessions of telepsychiatry, telemental health. And it's a lot more now because of all the other services we provide. But again, very sparsely populated, underserved population. And so we just launched and jumped in. So that was 96. We kept moving, growing. Then in 2020, we had a big surprise called a public health emergency from COVID, and we started doing in-home services. And then we are continuing to expand telemedicine throughout everywhere in the country. So today, I really want to focus on a couple of things. How do we measure success with telemedicine and telepsychiatry specifically? And of course, our first goal was access to care, right? We've got these vast spaces and we've got to provide care to these people. The way it was working was that these little towns couldn't afford a full-time psychiatrist or a psychiatric nurse practitioner who came into play later. And so access to care was everything that we talked about at that time. But patient satisfaction is another thing that we can talk about. Cost is what we can talk about. But what I really am going to focus most of this talk on is quality of care. So yes, we improved access to care. We were able to provide psychiatric services to areas of physician shortage. And you can imagine that map, but that I, from Flagstaff, was able to provide part-time services to multiple smaller need locations. And so that has been the biggest boon of telemedicine, I think, anywhere. But we also found some surprises in terms of access to care. We found that we had better team treatment, like people were able to come together and connect multiple distant systems, places, clinicians, family specialists. For instance, we could connect into the University of Arizona and get one of their specialists in neuropsychiatry or neurology or child psychiatry to hook in to the little clinic in St. John's, but also I could hook in and be part of that system. We could bring therapists from around the state. We could bring families to places where they couldn't normally be. And so the team treatment and the group getting together was amazing. But also we're able to provide more and consistent services. For instance, in order, let's say you have a child who needs to see a psychiatrist and they live in St. John's. That is a 3-hour drive. And for just, if it's an initial eval, it might be an hour and a half, but if it's a follow-up, it might be a 20 or 30-minute appointment. And for a family to have to drive all the way in, they would literally have to take the day off school, the day off work, maybe 2 days so they could stay overnight. And so people would not attend appointments as frequently as they was ideal for the child. And so patients can be seen in their own community. But they could also be seen sooner because we were looking at a model before telemedicine where we would have to maybe bring in a mental health provider kind of on a rotational basis where they would come in once a month for a week or people would have to take the bus or transportation into the big city. So we can see people more frequently than most a month. And we found, to our surprise, that attendance was better at our appointments, but also timeliness. We can provide emergency assessments immediately by just a click of a button. And what's really important is the providers are caring for people, not driving. So for me to get to Springerville and back, that's 7 hours of driving. I can do probably 3 or 4 psychiatric evaluations or 14 follow-ups in that time. Acceptance, patient satisfaction studies at this point are almost like boring, like everybody loves it. But we were able to provide one of the first ever 10-year follow-up studies of client satisfaction in 2006 that was published, and that has been just overwhelmingly positive with satisfaction over time. Cost, again, it's been efficacious in, especially in terms of travel costs and in terms of decreasing hospitalizations because we're able to increase access to care. So patient satisfaction, cost savings, access to care, that's all pretty well established in the literature and in people's experience. So let's talk about quality of care and outcomes in telemental health. And then as well, I want to talk about health inequalities and how we can maximize those. This is my favorite quote on quality of care. Tara Sklar, who is the Associate Director of Telehealth Law and Policy for the Arizona Telemedicine Program. She's actually giving a talk on the 11th next week on navigating the digital landscape. Which I've got a nice landscape picture here. Anyway, this quote I think is amazing. Expertise, ability, and therapeutic alliance are more important than proximity. And I thank her for that because I think of that a lot. The way I have been thinking about provision of care is I think about competence, like you got to know what you're doing as a professional, but also we need to connect in order to, with our patients, to come up with extraordinary outcomes. So I want you to understand that telehealth is an evidence-based practice. There was a recent research big compendium that Health and Human Services released looking at a broad range of services over telehealth, and they found no significant differences between the quality of care delivered remotely versus in person, but that also telehealth can reduce barriers like the transportation and time that I mentioned. But also patients attending remotely had an increase in appointment completion rates. We have so many studies demonstrating that telepsychiatry specifically is equivalent to in-person for assessments, diagnoses, therapeutic alliance, which we'll talk about later, treatment adherence, and clinical outcomes. So think about it. Like I can make a great diagnosis, I can make a great assessment, I can put together a great treatment plan, take these meds, do this, do all these things. But if I don't have a good connection and relationship with my patient, and especially when I'm asking them to do all kinds of really hard things, we're not going to have the outcomes that we want. So I need them to come back and I need them to trust me. So that's a big part of what we're talking about in clinical medicine. This was interesting. This is from Cambridge University Press. They spell things differently in England than here. But in their study, they found that telepsychiatry, this is a meta-analysis of random controlled trials, and they found that for symptom improvement, telepsychiatry was similar to face-to-face treatment, and there was no significant differences, also with all-cause discontinuation. So again, if I have a great plan and diagnosis, but nobody comes back to their appointment, then that's not going to get us anywhere either. One of the issues I'm passionate about is that telehealth must have the same standard of care as seeing a patient in person. And so, I mean, there's kind of an image, especially since the pandemic, of providers and patients sitting around in their pajamas, eating their lunch and not really doing all that they need to do. And that is a misinformation, although I do love my stretchy pants, I have to admit that. But when we're talking about telehealth, it is medical care and all the standards, regulations, rules, quality performances measures must apply, plus adding on top of that the telehealth regulations and recommendations. Anything that you do over telehealth must be clinically appropriate. It must be medically necessary for billing. And especially a medical professional, they're responsible to making sure that they have all the information that they need to make a good decision, to make a good diagnosis. And so if you're not getting that, you need to find out a way. And I'll talk a little bit more about how we can do that. But in terms of an examination or a physical examination, we can do a very adequate and exceptional and medically appropriate psychiatric medical physical examination over telemedicine. Here's some examples of what would be documented in a good psychiatric telemedicine evaluation in terms of a physical examination. The abnormal involuntary movement scale, that's this AIMS, is an actual neurologic evaluation that we need to do for people on antipsychotics. And we can do a very good AIMS, maybe even better than in person, because we can actually zoom in and really look at it if we want to. And so we can and do and must document that for our patients on antipsychotics. We can do a great mental status exam. And then if you are looking for more telehealth physical examination ideas, this is a great article called the Telehealth 10, a guide for a patient-assisted virtual physical examination. We also have to make sure that our medical standards are documented, that we're actually doing what we say we're doing. Arizona statute, this is the law. It requires that we provide informed consent to our patients prior to providing care via telehealth. So that needs to be documented that was done. And we also should document in the medical record that the services were provided however they were. So if it was via live interactive audio video telehealth, and then we also need to document that there's a need for effectiveness and appropriateness of the telehealth medium. If it is audio only, and we'll talk about this a little bit later, perhaps, please document that it's because the patient did not either requested or was unable to achieve video. In other words, think of it the reverse. It's not that the provider was too lazy to establish a video call is really, I think, the intent of that rule, but that the patient is the person who needs and requests audio. In terms of fraud and abuse and diversion, I'm not going to get too deeply in the legal weeds here, but I believe that one of the reasons that there's concern about fraud and abuse is about identity verification, especially of the patient, where you have a provider who is not actually verifying that they're giving the appropriate medication for the appropriate diagnosis to the appropriate patient. You also have to make sure that you're documenting in your record all of the things that you normally do in a medical evaluation. There have been some really high-profile investigations of fraud, and in general, it's felt like the fraudulent activity was due to the provider and not due to the modality of telehealth. This is not yet published. It's soon to be published. It's accepted for publication. There is no evidence of diversion of controlled substances via telehealth interventions versus in-person. So we've had all kinds of models through the year. I've been at this for almost 30 years. And we started out, the provider was in an office, the patient was in a clinic or an office or a hospital, and we had this expensive equipment. This is my favorite self-portrait. This was a little kid I was seeing who drew this when I was seeing them. You can see that there's me in the middle here, and this is our big old monitor. On top was our former big old camera, and then we had a telemedicine cart that this was all sitting on. But basically, nowadays the provider types and it was pretty limited in terms of the providers who could provide it, but now we've had a big expansion of provider type and the patient location as well as the provider location, and it is defined really a lot by the payer but also by licensure. For instance, CMS, which is Medicare and Medicaid, they have different rules than Arizona State, than private insurance. The patient location is broadening, but I can talk a little bit more about how that may be going away a little bit. But we can do outpatient, inpatient, subsequent care, nursing homes, prisons, legal in Arizona. We're able to do Title 36 evaluations, and that is a commitment evaluation where you're actually asking the judge for the patient to relinquish their own ability to consent. So it's a very big deal. And we're able to do those evaluations over telemedicine, but also testimony into the court system by their permission over telemedicine. We can see patients in schools, public libraries, chapter houses. There's been a huge increase in creativity and in places where we can set up systems. This is one of my absolute favorite concepts. We have vulnerable populations who move around a lot. So let's think about kids. A child in a foster placement or in DCS custody can often end up, especially if they have behavioral problems or mental health issues, they'll get moved around a lot. And in the old model, every time they crossed a county, and as you can probably imagine, in northern Arizona, in some of these really rural, remote areas, there aren't foster care placements in the same county. There aren't certainly residential care. That's down in or group home, that's down in Phoenix or Tucson. So they would move counties and they would get a whole new set of doctors, case managers, therapists, all the people that they knew would all go away and there would be a new set. And so the magic of telemedicine has been that we can take those vulnerable populations and follow them remotely and keep them in our consistent provider wing, which I just think is so important, especially for children, but also for vulnerable adults, people with in the LTEC system or who are placed in group homes or adult residential treatment. We are able to keep our same team and follow them and keep them under our link. So anyway, we had this whole thing going. Um, I was doing my telemedicine and everything was going along great. And then all of a sudden we had this little pandemic. And COVID-19 public health emergency came along and suddenly we closed our clinic doors and we sent all the patients in home. And this caused a revolution in what telemedicine was like. I kind of thought I knew it all, and boy, was I surprised. So suddenly we were bringing our mental health care directly into people's homes, and we had to develop a whole new in-home standard and guidelines. And as you are, I'm sure, well aware, that continues to this day. People love in-home care. But we had to develop a whole new paradigm of how this worked. I went from an office to and a clinic with a whole infrastructure in the clinic to just people in their house. And so again, we had to rethink how we were doing things. Bottom line, standard of care via telehealth is the same as it is in person. You are responsible for getting the information that you need. You can establish a provider patient relationship. You must have proof of identity. So in the old days, they were in a clinic, and so a staff or clinic had their whole process in person, and that previous contact can also move into the home. But if they're not in a place where you can verify their identity, they can show a picture ID, a provider can show their name badge. I probably should have mine on. If the session is over audio only, then you need to have some way to identify the patient. And there's all kinds of really cool biometrics that all the techie people are coming up with for telehealth proof of identity. But also, if somebody's in their home, there's a whole constellation of risks, and one of those is privacy. So you need the patient to attest to privacy, and also if it's a safe space. And you can ask the patient, and I found myself seeing a lot of people in their car in the driveway because they could be safe and they could be private in their car. And so the provider also must know the location of the patient. A lot of times they'd be driving and I'd say, draw, you need to pull over. But I also need to know where they are because if there's an emergency, then we need to know how to locate them and take care of them. Having the patient's medical record available is actually a telehealth standard of care. You don't just see people without having their whole medical record in front of you, but usually it does include their address in case of emergency, but 911 does not work remotely. And I didn't know this until a couple of years ago. Well, probably more than a couple, but so you need to know what emergency services are available for the patient ahead of time in CIC because people can be suicidal or can be overdosing or homicidal or assaultive. There's all kinds of behavioral health crises that can happen, and you might need to use either this E911 number or know like the sheriff department in the county where your patient is. So it's really important to know where they are so that you can know that they're safe, but also know where to send somebody if there's a problem. The other thing that was interesting about bringing services into the home was that some members would actively avoid the video call. And there was one situation where there was a kid where we were nervous about the parents, and they would not put the child on video. And so we ended up, sending people into the home and really looking around and seeing what was really going on there. But there's also just issues with privacy invaded. There's a great talk that somebody gave, I think it was one of the nurses at the Arizona telemedicine program, gives about where she has a slide of the patient sitting there in the video, and then she zooms it out, and there's just like chaos all around them, but you can't see that because they just are on their face. So there are those issues. But what I found was that it was scary at first, but patients would get pretty excited when we finally made a video connection. Find a kind human to help patients navigate the technology, and we'll talk a little bit about technology in a minute. But we also, we had more insight into our members' lives when we were able to go into their home, but we also got a lot of scares and concerns about how do we figure out getting vitals, drug screens, labs, those kind of things. And of course, the biggest issue that was really difficult was, we call it the digital divide, and I'm sure you've heard about this, but there's really three major components to this. One is equipment. Does the patient have a means to access telemedicine? Like we used to have the big $100,000 setup, with the big telemedicine cart, but a phone with video, well, they might have that, but they might not have internet or data minutes left in order to achieve a connection. A tablet or computer, they might not have it. And in Apache County, they didn't have it. Internet can be none or very slow. Broadband access is a big political want right now. And then do they even know how to use all this technology? So we did some things when we moved into the pandemic. We were able to get a grant to provide tablets with a data plan that we could bring to the patient's home for services. Like when things were really scary, we would have this tablet and the case manager would take it to the house, wipe it down with hand sanitizer, put it on the front porch, ring the doorbell, run away. Patient will come out, get onto the tablet, have their session, put it back outside. We did things like that. We did whatever we could figure out to be creative. Another thing to do is to have a staff member meet with the patient and practice connections ahead of time. That's really helpful, especially when you've got a teleprovider who's got, patients lined up every half hour or 20 minutes or whatever the model is. You don't have time to be figuring out how to connect in. And so practicing that ahead of time with the patient. And that's where I talk about the kind person to help them navigate that. That really helps. And then there's some other ideas on how to navigate that divide. Audio-only telehealth is continuously being evaluated by federal and state regulators, including Access, which is, if you don't know Access, that is our Arizona Medicaid program, and CMS is Medicare federal. And they're really looking at is our audio-only telehealth services high enough quality, And what about the cost and the access to care? And I'll just put out there that, especially in rural Arizona, we are continually finding people who are either unable or unwilling to access care in person or even via video conferencing, but they will seek out care if they're given an audio-only option. Again, we're talking about care here. So we've got a host of ongoing epidemics going on. We have a mental health epidemic and a suicide epidemic and an epidemic of opioids and substance use disorder. People who lack social connection, in addition, are thought to have an epidemiologic risk equivalent to 15 cigarettes a day. Telehealth can be one of our bridges to make a social connection to those who are difficult to reach. We know that we can establish a provider-patient relationship. It must be established, and that's Arizona statute. But it also, under law, we can achieve that relationship via telehealth in Arizona. You can do all kinds of things to try to make this technological interface invisible, because really what we're talking about is establishing rapport, especially in the mental health world. And we can do that. And the more you can do to just let the technology drop away and really let the skills of your profession bring you through the relationship is what you can do. And so a good provider-patient relationship plus good rapport equals a therapeutic working alliance over the long term and improved patient outcomes. It's kind of fun to see my hair over the years, right? So let's talk about therapy. It works. Virtual psychotherapy, teletherapy, even audio only is evidence-based efficacy. And in addition to being evidence-based, it also improves treatment access disparities in vulnerable populations. This was kind of cool. Postpartum depression, women who have just had a baby, they're at really high risk for postpartum depression and need to be followed closely, especially if they've had a previous one. And it's really hard for them to get out of the house. They've got a baby who just filled their pants, and they got to figure out how to get him in there in pain because they just had a C-section, and they got to get him in the car, and they're supposed to go into this clinic. I mean, it's terrible. The barriers for them to go in are really tremendous. And here they did telephone-based, nurse-delivered interpersonal psychotherapy for postpartum depression. And they found it to be very effective. And it was for both urban, it's just as hard to get out to and get to an urban site as it is to get to a rural site. And it really improved treatment access disparities. Also, virtual psychotherapy can decrease your therapy disruptions. National Institute of Mental Health studied of 110,000 people getting therapy, and they found that they were more likely to return for additional psychotherapy services than the in-person. I can talk about, if we have time, Melanie can let me talk about this, but there are certain diagnoses that actually have an advantage over telehealth, that it's easier for a patient to engage over telehealth than it is remotely. And basically, that little bit of distance is really helpful if you have a trauma history, if you have anxiety, that just gives you just a little bit of space. Another epidemic. We have a problem with opioids. And here are our Arizona statistics. You can go to this website. It's really sobering. But in 2024 in Arizona, we had over 4,000 verified non-fatal opioid overdose events, but almost 1,500 opioid overdose deaths. Heroin was a very small percentage of that, surprisingly to me. Prescription and synthetic were 97.8%, so that's like fentanyl or prescription drugs. And polydrug, meaning multiple drugs involved in the overdose, was also a big quantity of that. They like to talk about the waves of opioid epidemics, and we are in the fourth wave. I don't know if they've looked at another fifth wave coming on, but basically, think fentanyl, think multiple drugs. This was a talk that I received in 2024. He's coming back next month, and I'm excited to see. But in Arizona, the top 5 drugs, so this would have been for 2023 probably, were fentanyl. These were that were seen as a risk for the drug trafficking area. Fentanyl, methamphetamine, and then cocaine, heroin, and marijuana were distant seconds. For those of you who are younger, you might not know that this is a pencil. This is the tip of a pencil. It is very small, and this little tiny bit of white stuff right here is fentanyl, a lethal dose. And that's not even the higher strengths fentanyls that are out there. Here is in 2023, DEA would test the pills that they confiscated, and 7 out of 10 that they tested, 1 pill, lethal dose. And here's some of the fentanyl that was confiscated in Arizona. So, looks like candy, right? Sweet tarts. 95% of the overdose deaths in Arizona, children 17 and under were caused by fentanyl poisoning. Who's going to stop with 1? So opioid use disorder is really unique because it kills. People overdose inadvertently. They're not trying to kill themselves, and they die fast. So it's a really big problem. And what I want you to think about is that opioid use disorder is a chronic and relapsing illness. And medications for opioid use disorder are first line because they prevent death. And telehealth is an evidence-based practice for substance use disorder treatment. Our best outcomes are because it's chronic and relapsing. Our best outcomes are when people are retained in treatment for as long as possible. The longer the treatment, the better the results. And in 2023, here's a study of 92,000 adults, better opioid treatment retention when telehealth was used versus in-person. Better retention comparable to in-person, and a reduced risk for fatal overdose, 33% lower with telehealth versus in-person during the COVID pandemic. There's all kinds of stuff published about the importance and the evidence-based practices of treating opioid use disorder over telehealth. Medication-assisted treatment. This is SAMHSA's definition. We call it now, we've moved to different terms. We like to call it MOUD, if you see this terminology, medications for opioid use disorder, because opioids can kill you by stopping your breathing so fast, but these medications can prevent those deaths. So we like medication-assisted treatment for opioid use disorder because we get better outcomes in terms of treatment retention, because people on medication stay in treatment longer, but also harm reduction because there are fewer deaths from inadvertent overdose. The CDC last summer published that only a quarter of Americans who need this treatment in 2022 actually got this treatment of medications. And there's huge treatment disparities in populations. And also, when they looked at community mental health facilities, these are the people who are supposedly going to be treating are substance use disorders, but only a third of community mental health facilities offered this treatment. And so we really need to escalate our provision of this vitally life-saving treatment. SAMHSA's doing their part. They issued last year a new rule trying to remove unnecessary barriers. They took away that, it used to be, I think Suboxone is a lot of what I'm talking about, but also methadone. But Suboxone was just buprenorphine. It used to be, oh, you have to get counseling first, and then we can prescribe the medications. And if you stop going to group, then we're not going to do the medications anymore. But we're really taking that away. This is a model that I encourage you to look for. It's called medication first. And the basic concept is that we don't want to go through a lengthy assessment and treatment and interventions. We get them on the meds, save their lives first, and then we bring in the other treatments. We can also do in-home based induction of buprenorphine or Suboxone because it's now the community standard of care, and that's where telehealth can really help out. So, telehealth, I like to say it can improve outcomes. Again, we can be competent, we can be a proud professional in a community of practice. We can also, though, improve our connection and trust in every way we can. So tech is a healing modality that can support everything else that we're doing. Chronic diseases, like most mental health disorders and substance use disorder, they require a long-term relationship. And that is what we can provide any means possible. And we also have tele-mentoring programs that are amazing for supporting our clinicians. This is our Project Echo at Blue Cross. We have 3 that are going on every month. One where we get a whole bunch of people together, multidisciplinary, to talk about substance use disorder, one on trauma in children, one on social determinants of health. We bring in cases and we problem solve together. I'm not going to get into this a whole lot. If you have questions about it, we can, but there's all kinds of things going on the federal level. And one of those is the DEA. Think of the DEA as doctor police, police for the doctors. But basically, they care about controlled substances prescribing of controlled substances, which are things like ADHD, you've got Adderall, substance abuse, you've got buprenorphine, which is a controlled substance. Anyway, they have worked to expand some of the buprenorphine treatment via telemedicine and make that permanent. But there's this little thing about in-person visits, which providing that before seeing a person over telemedicine for controlled substance. And that right now it's being waived because of the epidemic and the pandemic, through the end of this year. However, there's a proposed telehealth prescribing rule that is open, very burdensome. It is ridiculous. So many barriers to care. It's in comment for like 2 more weeks. Here's some links so that you can try to advocate for abandoning that proposed rule. And then CMS Medicare, I'm sure if you're on social media, heard about this. The public health emergency flexibilities expire at the end of this month. And so really that's going to involve geographic restrictions and home services and affect behavioral health treatment. Urban areas will lose all of their Medicare telehealth access entirely, and rural patients can't be, and even if you are in a rural area, nobody can go in home. whether you're urban or rural, but only rural patients will receive Medicare services over telehealth. So this is a legislative issue. You have to contact your congressional representatives. This is the law. Arizona has been very supportive of use of telemedicine. So we're just beginning. It's all about connection, innovate, create, connect. I loved this during the pandemic. They had video conferencing in the bus, and then the kids would sit outside in their car so that they could go to school, even though they were being distanced. So what can we do? We can enhance regulatory support, please. We can mitigate fraud and abuse, and we can improve our provision of care and improve our quality. Technology is a support. It supports healing. It's not a distraction based on how we use it. And there are some other considerations here. But again, competence plus connection can lead to extraordinary patient outcomes, satisfied clinicians who stay in their job and don't burn out. And here's some guidelines. And then I'm done. And I'm just going to leave it on this page right here. Or should I log out? Or
No,
should I stop?
no, you can keep it there.
Okay.
We did have one question. We have there was a first-year medical student who's interested in psychiatry typed in a question early on, and I'm going to go ahead and read it. Unfortunately, she had to leave, but here's the question because I think other people might be interested in this as well. First of all, she said, it's amazing you've been in telemedicine practice for so many years and have seen its evolution. Can you share how your practice had to change or adapt given, say, lower reimbursement rates for telehealth services, even though the standard of care is the same? Did you experience a lower reimbursement rate? And funny enough, right before she typed that, I was thinking about, did you have issues with the payment parity or permission in using telemodality when you first started seeing patients 20 some years ago, compared to when the pandemic hit and all these regulations started hitting?
Yeah. You know, I guess I haven't really paid so much attention to the payment parity issue as much as think of it in terms of barriers to care, in terms of certainly parity in terms of what's allowable by various providers, but really it's a lot to do with time and evolution of perception. I mean, early on, Access, Arizona State was wonderful in supporting us in doing kind of whatever we could do to provide this care. And it wasn't, it was later that all these barriers started dropping in and dropping in. And then we hit the pandemic and so it was getting difficult. And then all of a sudden the pandemic came and they really relaxed everything. And now we're in this new phase of trying to pull things together. So, yeah,
Yeah, because before the pandemic, you had those small clinic spaces all over northern Arizona.
right.
So you had a professional there, although the patient wasn't coming to see you, they were seeing you, but at a distance at another clinic site. And when the pandemic hit, it's all those clinic sites that closed. And then you brought in that whole in-home piece. And now
Right.
the other clarifications and other rules. Okay, well, now if they're in their home,
Mhm.
then you had then became the other insurance issues and the payment parity pieces.
Yeah. Yeah.
Gotcha. That makes a lot of sense.
So it's really getting scary for the first time right now.
Okay. Yes, and you've been doing this for years, so that's an interesting piece, especially for a young student who's interested in psychiatry,
Yeah.
and what do they have to look forward to, and what, the different pieces that they're going to have to learn to be able to provide services like this.
Yeah.
So, and interesting, you brought up nothing I made a note of, the biometrics to prove identity, such as, say, like fingerprints, like Cell phones use that. They use the camera for facial recognition. My guess is there would have to be some kind of a setup in the patient's file for those specific biometrics then, depending upon what the provider or the program that they're using.
Right.
Right? Okay.
And I'm hoping that by integrating more of those, we can decrease some of the anxiety over the safety of telemedicine, because I really think that is that identification of the correct patient that people are afraid of. And all of those, like there was a case that was tragic where a young man, I think he was like 16, overdosed on Adderall. And when they looked into the case, everybody's like, oh, telehealth, it's terrible. Well, it was not in any way a medical evaluation. He had to answer one online question that was called a medical evaluation, and it was, do you have trouble focusing or something like that? And that was his whole medical evaluation. And then they provided him with a huge quantity of Adderall prescription that was filled, and he overdosed. And so it wasn't about the telehealth modality, it was a medical standard of care that was completely violated.
Wow.
Yeah.
All right. Let's see if we've got any other questions in the chat.
Yes, I'm terrible about chat monitoring. I'm sorry.
I did put a link in for the previous webinar that will be in there. I don't see any questions right now. But again, all of that information will also be in my thank you email to everybody that joined us today. And Dr. Gibson has got a lot of resources, a lot of information in her slides. Those will be available on our website with the recording as well. And you are able to peruse it and download those and check those links out yourself. Some of the active links that she's talked about, I will also have those as active links in the thank you email. Ooh. So we've got just about 3 minutes left. So if there's no more questions, again, thank you everybody for joining us today. And Dr. Gibson, thank you again. Dr. Gibson will be joining us again in September. Oh, we got one more question. Want to ask you if there is telepsychiatry prescription. If there is a telepsychiatry prescription is provided to the patients is recognized in the pharmacy.
Right now, they don't necessarily know that, but that's one of the rules the DEA is putting forward, is that you have to identify on a prescription that it was provided over telehealth, and that's one of the cumbersome things. And then the other part of that proposed rule is that the pharmacy is going to be asked to identify, to have accurate patient verification. And so the pharmacists are a little afraid about that. But right now, you just write a prescription and the pharmacy doesn't necessarily know if it's over telehealth or in person. But that has been one of the big things, is to identify a controlled substance, especially that it was provided over telehealth.
So a patient would be required to pick up their own prescription if it's as compared to, like, sometimes I go to the pharmacy and I pick up my mom's prescriptions. So,
exactly. And keep in mind, the concern is controlled substances.
Gotcha. Okay.
And so general non-controlled substances aren't the DEA does not care about that. They don't look at non-controlled substances at all. But Medicare does, and they have their rules. Right. And those are expiring the end of the month. So
interesting. All right. Thank you again, everybody, for the questions and for joining us today. Dr. Gibson will be joining us again in September and talking about telepsychiatry again with us. Please check out our website for other topics that are coming up. I'm in the process of getting them all scheduled. And as soon as I get a new one scheduled, those of you that registered for today, I'll send out a little reminder to say, hey, we got some more coming up, and you can come to our website and check it out. So without any further ado, we are right at our hour. Dr. Gibson, thank you very much. And Chris, thank you for making sure we're staying connected and everything is working in the background. And again, so please do that evaluation, and we look forward to seeing you again at another session. Thank you, everybody.